Hello, students. I hope that you are all doing well, and I'm really sorry that I don't have the opportunity to be with you guys face to face for this lecture because I like to have a little fun with the lecture and see how you guys are responding to the information because without a doubt, once you guys start hearing about certain disease states, you sort of personalize your own experiences and assign yourselves with those similar diagnoses. And this happens to be one that happens in a quite high ratio for students, but there are some things to talk about regarding that. So what I wanted to make sure that you understood is that I'm going to go into a lot of depth in this lecture online to make sure that you guys have enough of a foundational background so that we can engage in more of a discussion, talk about cases and scenarios, really kind of have a good clinical discussion when we meet on Wednesday and how we will kind of navigate through Blackboard Collaborate Ultra. Now, in your module, there's going to be different articles that I want you guys familiar with. It's not for testing material. It's really for foundation and for background. It's certainly something that will be a good resource for you guys as you go into your next academic year in terms of cases, but it'll be something to kind of keep in the background of things to think back on when you guys are in community practice, when you guys are on different rotation experiences. And so hopefully for those of you that might be working in the community setting, or you may know someone with an ADHD diagnosis, whether in childhood or in adults, you can be a source of good information because that's actually the most important thing for you, is that you're stewards of evidence-based information. So for our lecture, these slides were made and I just update them as new information comes out with the guidelines, certainly for things that I want you guys focused on. There was a guideline update in September and October of last year for the ADHD guidelines in youth, and we'll go in a little bit more detail in those, but I wanted to cover the core of the content for you guys from a pharmacotherapy perspective and really use our time in class on Wednesday to go into a little bit more depth of the guidelines themselves in terms of knowing information to give, to share, and where to help direct patients in your clinical team. Your learning objectives are listed. I posted a separate set of slides that does not have the voiceover because I want you guys to be able to have that information without the size of the document being so bogged down that it's not worth downloading and keeping. So understanding epidemiology and different etiology theories, looking at some of the key concepts in terms of diagnosis and treatment, talking about the pathophysiology and the neuroanatomy that's kind of underlying the disorders of ADD and ADHD, look at screening tools, looking at pharmacotherapy, looking at the variations in approaches to treatment and therapy, and then really kind of talking to you guys more on Wednesday about how my clinical site really folds into what we do with patients who have an ADHD diagnosis and the approach that we take from a primary care perspective, especially in pediatrics. It's not that it doesn't apply to adults, but this is the scope that they asked me to present to you. So I want to stay within that parameter. So in terms of background, we know that attention deficit hyperactivity disorder, or ADHD as it's commonly referred, is really a disorder that had its original identification in pediatrics. It was primarily thought to only exist in pediatrics, and everyone grew out of it as they aged. However, what we do know now is that ADHD diagnoses, once it's diagnosed in children, it will persist into adolescence in approximately 75% of the patients. And so, yes, there are children who, for whatever reasons, have some attention deficit behaviors younger, and they may age out of them, or there might be some environmental or other cognitive and behavioral approaches that seem to help manifest this growing out perception of ADHD, but we know from our evidence that 75% of it persists into adolescence and late adolescence, so up, in through your teens. But also that approximately 50% of those patients diagnosed as a child with ADHD will persist at some level into adulthood. And so we know that about 50% of those who are diagnosed, they will carry that forward. And if it's something that they're carrying forward, then it is certainly something that they can pass on to their own children. And so it is important to, when you're doing family histories, to really kind of look at those. Unfortunately, not a lot of parents of our children that we see have a diagnosis, so they don't recognize it in themselves, and so it's very foreign for it to appear in their children. When if you're doing really in-depth screening and family interventions, you start to pick up a significant amount of those behaviors in the adult or the parent. It is considered a chronic disease. It does require ongoing management. We have to titrate it at different points in time. That also includes titrating it around cognitive and behavioral therapies and other approaches to management and care. And it does require a lot of supervision and reevaluation over time. The same dose is not going to work at the same time. It's not going to work over the same, the same dose will not last the lifespan. And so as things change for that patient, there are modifications to the treatment going both up and down, right? So it sounds a little bit like stepping up or stepping down the treatment based on what the needs are. And so we'll kind of get into that a little bit later. In the incidence of us failing to identify ADHD as a diagnosis means that we have missed an opportunity for treatment. And in those missed opportunities for treatment, we do know that there's a significant level of negative psychosocial and educational impact. So if we don't identify it early on and we don't put the parameters in place for modalities for cognitive, behavioral, and medication therapies, there will be longitudinal impact. And we've seen this. There's been enough cohort studies, there's been enough longitudinal studies over time to see several of these incidents and how they manifest from a psychosocial perspective. And again, we can kind of get into that more in discussion on Wednesday. We have overdiagnosis that we have to deal with in this disease state. We have over-medication that we have to deal with in this disease state. And there's a significant area of diversion that occurs. And so it is the responsibility of the community providers, both in primary care and in community pharmacy, to really address these issues and look for red flags and concerns. We have had a lot of issues come up where the parents are diverting the kids' medications, whether it's opening the capsules and taking out some of the medication to use, and so then the child is not receiving a full dose, and so then the doses are increased, and the child really doesn't need it, to where there's a lack of parenting effort and a lack of consistency in parenting, and so behaviors that require effort from an environmental, cognitive, and behavioral aspect are not being followed through with. And so the ease is to add more meds because it takes a whole lot more effort to change the behavior of the family. That also impacts the parenting and the behavior of the child or the patient. So we do have to address a lot of these issues, and so we have to kind of manage that from a perspective in primary care. We see that there's variations in the way that ADHD presents clinically. There's different environmental expressions, so it makes it a little frustrating sometimes that the patient can function in one area, but it doesn't always affect them the same way in other areas, and so it almost appears or can lead to a level of frustration where when the child wants to behave or pay attention, they can, and when they don't want to, they choose not to. So there's a real misperception of what this disease state actually is and the challenges that it brings, not only to the patient, but to those around the patient. in the learning environment, the home functioning environment, after school, jobs, and in relationships. And so it's really different as it manifests and grows with the child. And it can have a lot of environmental impacts. And because of other comorbid issues, we kind of have to think about some of the additional needs for management to really be a comprehensive provider and optimize care. We use pharmacotherapy to decrease the symptom expression and allow for appropriate learning and development, but it cannot just be limited to medication management. There has to be a cognitive and behavioral component, and that's chronically the deficit that we see in our families, because when a child has a chronic disease, it requires the family to manage it. And if the family chooses not to do those things or follow through or adhere to their treatment or their role in treatment, we end up with a lot of challenges. And we can, again, talk about some of those on Wednesday. The criteria that we use to establish the diagnosis of ADHD has a lot of overlapping comorbid psychiatric disorders. And through the differential for diagnostics, we look at neurologically, psychologically, and physiologically. We look at the pharmacokinetic and pharmacodynamic properties and how those might alter how the person will respond to medications. And so it's important that there's a lot of communication and relationship built with our families to optimize what's happening with the ADHD medication, but we also see glaring gaps for parenting and the responsibilities and the importance of things that the parents have to do, because this is not simply a disease that gets fixed with a medication. It's like telling a person with a heart disease that they don't have to change their lifestyle, or a patient with diabetes that they don't have to change their lifestyle. So this is the common misnomer in ADHD treatment, and why we have so many coexisting issues and failures when it comes to the successful management. Now, there's different modalities that we use to successfully manage ADHD. And I've kind of mentioned that before, but we use behavioral, we use pharmacologic or medications, and we also see a surge of nutrition and supplementation. Then there's a lot of algorithms that exist for that successful titration, what we do, how we check back, what we're monitoring for, different observations. We look at adverse effects. We want to minimize the adverse effects while we're trying to mitigate the symptoms of ADHD, and we want to make sure that we use, again, the least amount of medications, but we can't be afraid to use the medications that are bringing us success. And it's a hard thing to discuss medications with families, especially when there's a family stigma toward mental health issues or ADHD. When we talk about the epidemiology and the etiology of ADHD, we do know that it is the most researched neurodevelopmental disorder of childhood. In family studies, the relative risk of ADHD is 6 to 8 times higher among first-degree relatives versus the general population. So again, this is something that we spoke about, is that if you have ADHD, then your child, right, because you're the first-degree relative, has a 6 to 8 times higher relative risk. It doesn't mean that they will also have it. They may have a milder expression of it. They may respond differently than you did. But it is important to know that there is a familial association. And so we do know that there's heritability in estimates. And so how you inherit, right, or how you track a lineage in a family, we see that there are between 40 and 90% familial estimates. So we know that it's a very strong presentation in genetics, and we see it in family lines. No different than what we see with ADHD and some of the other chronic diseases that we treat in childhood. So in 2010, and although this was 10 years ago, we haven't seen much of a change over time. And we do look at population studies to see how these different presentations exist. And so as we see changes in different chronic diseases, we will continue to see changes in the literature. So you may see fluctuations in some of these numbers, but what I want you guys to understand is that there's relationships here, right? So in children between the ages of 3 to 17, 10 years ago, there were 5 million. We know that that's a much greater incident now, but because we have so many different groups that are studying this, there's a lot of variation. So we know that it's more than 5 million children, right? We know that. If it's the number one neurodevelopmental disorder that's researched, we know that there's a ton of information out there. And 10 years ago, we were at 5 million, and those were only the ones that were clinically diagnosed. We know that the incidence is a whole lot higher. What we do know is that boys are twice as likely as girls to be diagnosed. So it's a 11 to 12% versus 6%, right? So it's 2 times more likely to be diagnosed in boys, because boys at that age group, in the younger age group, have a tendency to be more physically motor energized, where the girls tend to be a little bit less hyperactive. And it's something that is comparable with adults. We still see a little bit more of that presentation in males, adult males, but it's not that it is actually occurs more, it's just diagnosed more. So it's really important to know that incidence and prevalence has a lot to do with who is captured in the diagnostics versus genetically who actually has these underlying disease states. The other thing that we know is non-Hispanic Caucasian and Black children had greater rates than Hispanic and Asian children. And that's not always the case with chronic diseases. Normally, your minority populations are have a more negative chronic disease profile than your non-Hispanic Caucasians. And so why this disease state shows up in non-Hispanic Caucasians could either be that there are more parents seeking that diagnosis and assistance because they have less of a concern with the stigma, or that they have more resources to identify and support their children. There's a lot from a public health perspective that comes in with equity, disparities, those sorts of things, but we do know that there is a pretty high presentation in Caucasian and Black children compared to other ethnicities. We also know that prescribing for ADHD medications in children in the past 8 to 10 years has increased almost 50%. So where we didn't always see children with stimulant medications, we see this extremely frequent and high frequency now, especially in elementary schools. Children with disparities have a tendency to have higher rates. And so we see that pretty frequently. And unfortunately, we don't have that matched environmental and behavioral support that allows all those children with these diagnoses to thrive to their fullest potential. We have both the genetic and environmental factors that come into play when we talk about the pathogenesis of ADHD. We know that it's a polygenic disorder, which means that we bring in a lot of different genes that can contribute to this disorder. It involves multiple cholinergic receptors and CNS genes as well. And so it goes beyond the catecholamine systems, which are the focus of the majority of studies. And we really start to see a lot more in the literature that's kind of leaning towards these different genetic links and multiple neurotransmitter influences. We do know neurotransmitters that are in high impact with the presentation of ADHD happen to be our dopamine receptors, our dopamine transporter receptors, serotonin transporter genes, and norepinephrine. in which a lot of these are the targets for the medications, and so those pieces come together and make sense. There is a high comorbidity between autism spectrum disorder and ADHD, to the extent that we see almost 30 to 80% of patients with autism have co-occurring ADHD. And with Tourette's disorders, those estimates are about 50 to 60%. It's a much smaller range, so we know that there's about half of those disorders have a coexisting ADHD component, where with autism spectrum, it could be anywhere from a third to almost, 3/4 or more. So there's a much broader range with the autism spectrum disorder, but we do know that both autism disorder and Tourette's have a high incidence. Now, there's a video here about Tourette disorder. It's a great video. We don't have time to pull this up in the recording, but I may pull it back up to show you guys in class on Wednesday, because it's really important for you guys to understand the frequency in which we treat ADHD and Tourette's, and how there's so much need for research in those coexisting areas. We also have a lot of information and research being investigated or invested in other inflammatory disorders such as asthma, eczema, and obesity. So we really do see a lot of inflammatory overlap diseases. And so anything that is linked with inflammatory conditions either might be a causative factor, it might have similar overlapping genes, or it may be that these all fall under inflammatory disorders in some way, shape, or form, and that's why we kind of see them in high incidence and prevalence and when they coexist. So this is just kind of, again, giving you guys a little bit of background, and we'll discuss a little bit more of this Wednesday. Now, in terms of the pathophysiology, we know that there's structural and functional changes that are involved when we look at the pathophysiology of ADHD. So we know, again, pathos is the disease of how something is supposed to work, or there's a disorder in the way something works. And so we know that there's structural and functional changes that are leading to why these systems don't work like they're supposed to. And so 3 big areas of structural and functional change are delays in the cortical thickening. So if you have a delay in that cortical thickening, that is often associated with the difficulty in prioritization of attention and tasks. So do you know what you need to be doing, and can you stay on task with that to complete different projects, complete different assignments, complete different commands? Or is there difficulty in prioritizing that? If someone is given too many tasks to do, they become overwhelmed, they can't sort them out, and then we kind of have this executive function overload. There's also a lack of connectivity between the prefrontal cortex and the precuneus, which is the midline kind of the parietal lobe. And where we have the precuneus and we have that prefrontal cortex, we need connectivity between those. We need the neurons and the axons and the dendrite, everything firing. And when there's a lack of connectivity, there's a failure to suppress the modal network, and that causes kind of lapses in attention and poor impulse, right? Those things need to be regulated in order to be functional, and when there's a lack of connectivity, it's dysregulated, and it's that dysregulation that really leads to that inattention and impulse issues. We also have imbalances in the dopaminergic and noradrenergic systems, and the noradrenergic systems. We kind of see a lot of research happening in that, but with the dopaminergic, we see overlapping in a lot of other disease states. And so together with these 2 neurotransmitter systems, these are the targets for our pharmacology. where we're really focusing in on the dopamine and norepinephrine transporter blockers, right? So that's we'll kind of get into that. And hopefully it's not the first time that you guys heard it. When we talk about the neuroanatomical changes that contribute, we look at how things present clinically and how they're related to executive function. And executive function has to do with your ability to observe, process, track, draw back into, make decisions, stay on task, filter out stimulation. All of those things are part of executive functioning. And when there's dysregulation there, you have problems continuing to stay on task, problems getting started, problems sorting, problems, letting things go. And so we see a lot of overlap with different mental health issues because of these different presentations in the executive functioning. And so when the modal network is activated during the resting state, when attention is not engaged, and it's actively suppressed during the active attention. And so it's sort of saying that when it needs to be in rest, it's activated, right? So it's not functioning the right way. And when it's supposed to be, actively engaged, it's suppressed. So it's almost like it's working in opposite of how it should. And so there's a problem with, if you're supposed to be paying attention and you're not, you're missing the opportunity to input into short-term memory, which won't convert to long-term memory. If you're trying to focus on something but you're completely distracted, then you can't process. So it's both in the resting and active attention states that there's a problem, and the executive function is impacted as a result. We do know that therapeutic doses of stimulants will normalize the structural and functional brain deficits, which helps to improve the symptoms of impulsivity and inattention. And that's the modifiable risk factors, right? We have certain things that we can't change that have to do with genetics, age, gender, ethnicity. But when we can control these structural and brain deficits with pharmacotherapy, and we can also change them with behavioral and environmental approaches, that's where we have the opportunity for modifiable risk factors. Now, this is the precuneus, right? This is the part of the brain and the prefrontal cortex, right? Our eyeballs are down here. So when there's a dysregulation in connectivity here, this is part of where we get these lack of attention and impulsivity issues, right? And so it's just kind of giving you guys a visual of there's different disconnects in parts of the brain. We need these things to be able to have a really functional modal network. And when we don't, we start to see problems present. Now, the reason that I like this image is it really kind of helps to give you guys kind of a snapshot of the things that are going on, right? We have dopamine, we have norepinephrine, and we have serotonin, and these are our big three where we really have a lot when we're talking about, kind of from the ADHD perspective, the dopamine and the norepinephrine. Now, in the normal function, dopamine helps us deal with alertness, right? We need to be alert when we're supposed to be, and we need to not be alert when we're supposed to be at rest. Now, when we have appropriate dopamine release and function and absorption, we have an active working memory, we have a balanced motivation, and we have clarity. But when there's a deficit of dopamine, whether it's not being released from one synapse, it's not being reabsorbed, or it's not being connected to receptors, then we have hyper memory, we have compulsive behaviors, and we have a lack of clarity, so this fogginess and distractibility. When it comes to norepinephrine, and we're looking really at that concentration, we see in normal norepinephrine function execution behaviors, perseverance, the ability to recall. And when we, again, have those deficits in norepinephrine, we have hesitation, we have obsessive compulsiveness, right, or obsession kind of issues, or distractibility. And then we have doubt. So if you're not really sure where to recall it, if you can't remember, it's not moving forward, between dopamine and norepinephrine, we have a lot of this attention issue, right? When we bring on the serotonin, we have our learning memory, we have our pleasure and pain, and we have relaxation. And so that's where we bring in deficits, confusion, anxiety, and restlessness. So on the bold sides of each of these neurotransmitters, you see the positive of each of those on our function, and in the parentheses are what happens when there's a deficit of that neurotransmitter. And so when there's dopamine and serotonin, we have appetite issues. When it's norepinephrine and serotonin, we have intuition or perceptibility issues. All three of them are taken into account with mood. And then the dopamine and norepinephrine have a lot, to do with our attention. And so you can see why these three have a tendency to overlap when it comes to obesity, ADHD, and then other inflammatory issues, right? So it's really an important slide conceptually if you understand how to read these different circles. So you've got the dopamine circle, you've got your norepinephrine circle, and you've got your serotonin. It does come into play with our comorbid disease states, but the two that are some of the bigger ones for attention, again, are our dopamine and norepinephrine. Now, I want to show you guys this slide. This comes out of one of your McGraw-Hill med books, and it really kind of shows where these different neurotransmitters act on in the brain, right? And so we have our prefrontal cortex, right? We have here our brainstem, and so we see that we have a lot of functional places where norepinephrine really kind of sets off, where dopamine really sets off, serotonin, and acetylcholine even. And so we know that all over the prefrontal cortex, all of these neurotransmitters are key, but when we see how they function to move between the precuneus areas, right, they all touch in that space too. So it's important for us to understand that these neurotransmitters really have a lot of functional responsibility in the brain, and anything that dysregulates what we need is certainly something that's going to cause a disruption. And that disruption is definitely something that we see manifest in ADHD behaviors. Now, the brain regions that are involved in stimulant mechanisms of action, the reason that we choose stimulants as the primary line of therapy for ADHD in pharmacotherapy is that we know that when there's ADHD, we have a dysfunction, and with the stimulant, we end up with normal function in that region of the brain, right? So when we talk about this, the striatum, including the caudate, we're looking at the normal function. So stimulants help to normalize motor function and some cognitive learning functions. And so there is a reason why stimulants work in these areas. In the substantia nigra, it's the source of dopamine neurons that project into the striatum, and they're involved with movement and reward. So if those are dysregulated, the stimulants can be used to bring regulation back to movement and reward, right? And those are common areas that we see as triggers set off by ADHD. When we think about processing and conscious perception of sensory input, so how they are processing, how they're inputting their sensory environment, that is the region of the brain is in the thalamus. And we also know that the dopamine acts in the thalamus in the arousal and sleep cycles. And so we also know that patients with ADHD have disrupted arousal and sleep cycles. Oftentimes they might be drowsy during the day, they might be hyperstimulated in the evening, or they may have cycles with that. And so we know that this really has a lot to do with dopamine dysregulation. On the frontostriatal circuits, those are a series of circuits that are thought to control the ability to self-regulate behavior. So being self-aware and understanding when your behaviors are interfering with others, when you might be seeing somebody who's constantly poking or touching or doing things, they may not be aware of how disruptive that is, and that's why we end up with quite a few social behavioral issues with children with ADHD, or even with adolescents who have not learned self-regulating behaviors. And that's where it's really important to have cognitive behavioral therapy on board. That frontoparietal circuits that get affected by stimulants is that focus and shifting attention. So they're able to stay on track, they're able to shift their attention appropriately, and it decreases the distractibility. So we do see that in specific areas of the brain, stimulants normalize function. Now, when we talk about the diagnosis and screening of patients with ADHD and other Tourette's and developmental disorders, we have this idea of aging out, and it is present in ADHD, and it's documented in the literature, and it reflects a decrease in symptom presentation of about 50% every 5 years between the ages of 10 and 25 years of age, right? So as a child is 5 years, or as a child is at age 10, every 5 years there's a potential for symptoms to decrease at about 50% of that rate, right? So from 10 years old to 15 years old, there could be a 50% decrease in symptoms. And from 15 then to 20, and then from 20 to 25. So if a child may have the opportunity to age out or grow out of, they may not need to have ongoing ADHD treatment past their mid-20s. But that is also in context of saying that about 50% of children who have an ADHD diagnosis go on to be an adult with ADHD. So we know that it can occur naturally. We know that sometimes it has to do with the other modifications that have occurred, including environment, cognitive behavioral therapy, managing comorbid mental health issues. And so when you really do manage these to optimization, you can see how over time there may be a balance, and some of it has to do with that self-regulation. Some of it has to do with understanding the kind of environment that a person needs to be in to thrive and function. It's really important to distinguish behavioral, developmental, and other medical conditions when we're trying to do the differential in ADHD, because when there's developmental disorders, it's not uncommon to need ADHD medications to help with optimization of the cognitive function of some of the brain in those children. Other medical conditions might benefit, and some might be negatively impacted, and so it's really important to understand what those are to reduce the chances of doing that. Approximately 80% of our patients have a comorbidity with at least one additional disorder, and 67% have at least two or more disorders. And so anxiety and mood disorders are commonly misdiagnosed as ADHD. And so that's why, again, we see an increase in all these ADHD diagnoses when some of them may truly be an ADHD diagnosis, but we know that we commonly prescribe ADHD to an anxiety or mood disorder. And so it's really important to have a full differential, the full history, monitoring, managing, kind of layered approach to ADHD management, because if we miss the underlying anxiety and we miss the underlying mood disorders, we can manifest worse things with a stimulant, but even worse than that, we can miss the opportunity for an improved quality of life. And so we want to decrease risk, right? So we want to reduce harm, and we want to, mitigate adverse effects. And in order to do that, we have to be very comprehensive, and we have to be very astute in our diagnosis and in our management. Now, before moving on, I want to make sure that we know that we are, able to go down each of these different algorithm branches, but that's not the primary focus of the lecture, right? Your predominant ADHD branch is. When we're looking at the clinical presentation for the diagnosis and treatment, we look for the American Academy of Pediatrics and their guidelines for diagnosis, evaluation, and treatment. And as I mentioned, those were updated at the end of last year, and we're seeing, some errata or some things that are being fixed, but the actual guidelines were completed in 2019. So we see the onset of symptoms before 12 years of age. This used to be different. We would want to say that the onset of symptoms were earlier, but as long as the onset of symptoms are before 12 years of age, then this is the presentation of symptomology, right? So we're kind of really looking more at this pediatric aspect versus an adult diagnosis. Now, the symptoms there has to be greater 6 or more symptoms that have to be present for 6 consecutive months. And only 5 are needed in patients that are greater than 17 years of age, right? So you don't have to have as many as you start to age. There has to be significant impairment in 2 or more settings. Typically at home and at school is where we evaluate them. And that the symptoms must be documented by both the parent, the teacher, and the clinician. And so when we use some of our Vanderbilt screening tests, and we'll look at those on Wednesday, that's why we see them for the parent, the teacher, and the clinician, because we want to see how these things are captured. The symptoms are related in the 2 main areas of inattention. There's 9 items there, and hyperactivity and impulsivity in 6 items. So these are your clinical presentations. You have to have 6 or more symptoms present for 6 months if you're less than 17, and only 5 if you're 17 or more. And you have to have significant impairment in 2 or more settings, right? And so let's go ahead and look at the 2 areas. So in the inattention symptoms, we often see, right, these are not the end-all be-all, but the common symptoms are they fail to give close attention to detail or make careless mistakes in schoolwork or at other work tasks or during other activities. They have difficulty sustaining attention in play activities or tasks, difficulty sustaining attention in lectures, conversations, and lengthy reading. Now, when I say this, typically I'm in front of you guys as a class, and everyone in class starts to get really big eyes thinking, wow, this is me. I must have ADHD. Now, it's really important to balance the fact that you're in graduate school, you're being pushed beyond the norm to handle a greater volume of material in less time than somebody else would have. And so that added to different workload, plus trying to work, plus being on rotation, plus having homework, plus being in organizations, plus trying to do all of these things. There's a difference between being overextended and truly having ADHD. You may be overextended and therefore disorganized, having less than normal attention to detail, having tasks that require sustained mental effort and struggling there. That's the nature of being in graduate school. So we end up with a lot of students who feel like they have ADHD and they are diagnosed with ADHD when they just might simply not have good time management and the ability to filter out where they need to focus attention. But I am not saying that it is not possible for students to have ADHD, especially as adults. But this is what we tend to see in peds. And it does, it absolutely extends into adults. Difficulty organizing tasks and activity, time management, disorganization, missing deadlines, oftentimes delaying starting schoolwork, lengthy papers, preparing reports, right? So those things, there's a high level of distractibility. They don't seem to listen when they're spoken to directly. Their mind kind of wanders off. It's not that in lecture that this happens, right? We just know that sometimes we're boring and the content isn't very entertaining and therefore you're not paying attention. But this is in when the desire is to do so and you can't, right? Does not follow through on instructions, easily distracted by extraneous stimuli, so unrelated thoughts, forgetful in daily activities, losing things that are necessary, keys, wallet, school materials, right? And again, everyone thinks this is me. This is definitely me. And it might be, but it doesn't mean you have ADHD, right? It means that you're in graduate school, we're in the midst of a pandemic, you're balancing an abnormal level of credits, and you're probably overextending, doing a whole lot more than you should be doing instead of just going to school. But let's face it, that's reality. On the side with hyperactivity and impulsivity, we see a lot of fidgeting with the hands or feet, squirming in the seat, leaving the seat when remaining sitting is the expectation, running about, climbing excessively at inappropriate times, and especially in adolescence, the report of feeling restless, and a lot of times like this restless leg type stuff, sleep disturbances, those sorts of things. Difficulty playing quiet, often appear to be on and running, almost as if like motorized. Excessive talking, so hyperverbal. Blurting out answers before a question is even completed, not waiting turns in conversations, constantly disrupting, having a hard time waiting their turn to be picked on, or not picked on, but chosen to speak, and then interrupting others very impulsively, and not intending to be disrespectful in it, but just clearly having a lack of self-regulation, right? And again, a lot of you are going to be internalizing these as things. Inattentiveness and hyperactivity and impulsivity is what you're struggling with. But again, if you had a different environment, would you still have these symptoms? And in the midst of changing the environment, these things still exist, then we're really talking more about the potential for ADHD. Now, the American Psychiatric Association Diagnostic and Statistical Manual, that you guys know as the DSM, has their 5th edition. And this is what we use from a mental health side and from a primary care side too, to diagnose ADHD. It was originally released in 2013, and they've said that they're probably not going to go to a DSM-6, but you never know. It is the diagnostic standard. It ensures appropriate diagnosis and treatment for patients with mental health disorders or psychiatric disorders. And it helps to standardize and contributes kind of the measurement for public health impact. So where do we see that we need public health or population health initiatives to address these kinds of disparities within a given community? There are some changes to the DSM-5 for the diagnosis. Symptom can now occur by age 12 rather than by 6. So at 6 years old, it may not be presenting. And by the time the child hits 12, we may be seeing some of that a little bit more predominantly. There are several symptoms now that need to be present in more than one setting rather than just some impairment in more than one setting. So you have to see multiple settings with several different levels of impairment. And the new descriptions added show what symptoms might look like at older ages. And so what we see in younger children and younger adolescents may look very different than what we see in adults and older adolescents. And so again, on Wednesday, we'll go in on the chad.org and kind of look at some of the clinical practice tools. This is a fantastic resource for families and clinicians, and certainly for those people who are going to be interacting with and supporting the teams that are treating patients with ADHD diagnoses. And so this is children and adults with attention deficit hyperactivity disorder. So CHAD is the national organization for that. Now, this is your National Resource Center for ADHD. This is some different hyperlinks, and what I'll do on Wednesday is really kind of take you in and look at different areas of the CHAD website so that you guys can have a level of familiarity with it and see some of the resources that they have available. There's different evaluation and assessment tools, and those we're going to really kind of focus on again on Wednesday. You guys have the Vanderbilt assessment scales. You've got the parent scale, you've got the teacher scale, the clinician, and then it really kind of talks through like how to use these tools and what it's important to do in terms of reassessment, right? And so the CHAD website is just a phenomenal place to go for parents, families, clinicians. There's also Attitude, which is another professional organization that has a lot of webinars for professionals. And so it's really an area, if you have interest in psych and mental health, this is certainly a high predominant disorder and has a frequency of comorbidity with other mental health issues. There's different rating scales and checklists, and so several of these kind of overlap some of the other functional and bright futures. So depression scales, some of the other health literacy. So you'll see some of those, but these are put out by the American Academy of Child and Adolescent Psychiatry, supported by the American Academy of Pediatrics. And so whether it's a self-report scale, if it's an observation scale, depending on the age, there's different tools that can be utilized to observe and manage. And so, you know, again, looking at these resources for learning and attention, it really kind of helps teachers look at and learn how to work with children who might have these disorders, giving support to them, looking at community events, you know, again, looking at the signs of ADHD and how it changes at different ages. And so it's really important to know where you can go for good evidence-based medicine, things that are helpful for families, because a lot of our families, although they might be educated, don't necessarily have the health literacy to understand some of the research behind it, where this has an excellent platform for presenting to patients and families. Now, when we look at pharmacology and its impact on treatment outcomes, we really understand that suboptimal treatment is common, right? So there's usually a reluctance by the parents to initiate psychotropic medications. And so it's in that gap where the child begins to develop other problems, right? And so the learning disabilities, the social stigmas, those things, it's pretty tough on a kid to come back from that. We have issues of stigma regarding mental illness. And so some of the ways that we approach it in my clinic is we call it healthy learning. Instead of asthma, we have healthy breathing. Instead of obesity, we have healthy weight. And instead of ADHD, we have a healthy learning pillar. And so that's where we really try to help to remove the stigma of mental illness so that we can get more engagement, involvement by the family to reduce abuse, neglect, and to optimize outcomes so that the child does not have social issues with their peers and they don't have deficiencies in learning. Deficiencies in the delivery of healthcare by providers is very common. They rely solely on medication, and instead of doing referrals for cognitive behavioral programs that we know are essential, instead of balancing environments that are not overstimulating, keeping structure, you know, having additional patience when you're dealing with your children that have these disorders, those deficiencies in delivery of care and support and resources to families is another reason why we have such suboptimal treatment. The economic burden of the disease itself is quite high. We have over 1.6 billion in direct treatment associated costs. So whether it's medication, therapy, travel to, you know, co-pays, additional testing, all of these different things. And with impulsivity and those sorts of things, there could be broken legs, sprains, there could be broken windows, all of these different things that come, in terms of the direct effects of the disease state. Plus, we have the 2.6 billion in the loss of work or functional productivity. So when people are not fully functioning, when they're not fully able to contribute, we lose that work function. And so sometimes they have a difficult time maintaining a job because they're not in the right structured environment, or they haven't learned, again, those self-regulating behaviors, or they haven't adopted the different cognitive and behavioral approaches or modalities to help them be successful in that plus medication management. So when we think about pharmacology and its impact on treatment, we do know that our first line is stimulants when it comes to pharmacology. Now, we want parents engaged, we want behavioral approaches as a core part of our treatment, but we know that most of the time those aren't enough. And because of some of the different the differences, and those differences are very, very subtle, you might have to go through several different medications in order to go to find the one that fits, right? And it's very frustrating because you might find one and it's working, or you might find one and it doesn't work, and then you try another one and it doesn't work, and you try another one and it doesn't work. And so it can be a very frustrating process for both the child, the teacher, the family, and even the clinicians. So what's important to remember is that just because you fail one doesn't mean the whole class is out. Go through the list, and you start off with the immediate release, and then you work your way up. Sometimes you have to do both intermediate and short, or you may have short and long, but there's different combinations, and when you find that perfect fit, then that's really where your base of therapy becomes, right? So what we do know from the evidence and literature is that 2/3 of children and adults have equipotent responses. And so the agent should be chosen based on the duration of action that's needed, the formulation preference that exists, and of course the cost, right? And so some medications are not going to be covered until you fail those therapies. And so again, this is where it's really important to have advocacy on behalf of the patients and the providers so that they can push forward on a prior authorization if they need to, especially in light of how insurance companies can change formularies, and then all of a sudden the drugs that you're taking may or may not be covered. So it's really important to be astute and be aware of that, and to support your clinical team. And they depend on pharmacists for these areas. Our most common stimulants are in the methylphenidate and amphetamine classes. And again, we have all three, short, intermediate, and long-acting formulas that can be utilized in treatment and improve functional status. And again, because we know that suboptimal treatment is so common, and there's a lot of parent reluctance for stimulant medications, this is where it takes a lot of relationship to overcome that. Trust with the provider team, exercising every opportunity to provide supports, education for the families, education that can come from different modalities, whether it's the church, whether it's the matriarch or patriarch in the community, the coach, a strong relationship with the teacher. And anytime there's a breakdown in those relationships, there's a reluctance for help. And when a parent feels very overwhelmed and frustrated, we see an increased risk of neglect and abuse in our children. And so it's really important for us to really think about everything that goes into when a child is not optimized in care. This is the attitude.com, that the magazine. It's got a list of chart stimulants, and I've downloaded several of these resources for you guys to make that easier. Now, these are snapshots from your text. I don't expect you to be able to see, read, or focus on these, but I just wanted to show you guys that we have a bunch of different stimulants. We have non-stimulant medications. As you go through your text, you'll see the drug brand name, generic, the usual child dose, the usual adult dose, how it's available, so what their formulations are, the expected duration of action, and how you would go about titration. And so it's important for you to understand that there's guidance in these, but for the purposes of your exam, there's too many options for you to go through and memorize them all. But when you are given opportunities, it will follow your algorithm. So it's important for you to at least be familiar with classes and some of the names. This is just another snapshot of an image, again, showing in the stimulant how we've got multiple formulations, different and varying and overlapping durations of effect, how you would do the initial dose and then the available strengths for that, your dosing ranges, maximal doses. So again, there's so much information out there that it's not expected for you to be an expert in this. But again, you do need to be able to navigate with the algorithm, and you would need to be able to think about some common sense effects from drugs. Now, I have put these tables together summarizing some of the more common drugs that we see, starting with your methylphenidate formulations. We have immediate release, sustained release, extended release, right? And we have controlled, we have long acting, we have extended, we have a sustained again. We also have patches, and then we have these different suspensions and chewables. And so as we have different formulations, they're going to be continual things that come on the market. And so it's really important as a person in pharmacy that you understand who it is that you're working with. Who are your clinical teams? What is the dynamic of your patients? Because that's how you start to learn your most important formulary drugs. You'll never know everything, but as long as you know where to go to get information and how to stay current with information, that's where you become really the pillar of excellence in clinical care. And that's what we want from you guys. Now, we see how some of these immediate release can sometimes, based on their formulation, be either a 3 to 4, which is a relatively short, to something that lasts 6 hours. And so depending on the formulation, it's the same methylphenidate derivative, it's just in different formulations, and those different formulations can have profound differences in efficacy in the patient. And so this is where it comes back to saying, if they fail one, don't give up the class, right? Go through the list. And we'll kind of talk about, if we start off with short acting, we think about their schedules. We want to make sure that they're, off their dose so that it's not disrupting sleep. And if we start to have different disruptions, what can we do regarding the timing of dosing, right? And so that's going to be what we focus on with our lecture on Wednesday. Now, our amphetamine formulations, similarly, we have immediate release, solutions, spansules, extended release, long-acting chewables, orally disintegrating tablets, a suspension. And so again, as we start seeing different formulations becoming available, we'll see with these shorter acting medications how we might consider dosing those versus long-acting. And again, Wednesday's really where we're going to be talking about opportunities to dose. Now, what you do not see is mixed stimulant. We will not have a long-acting methylphenidate and a short-acting amphetamine. You stay in one class and exhaust that class before you go into the other, right? You will not see, should not see, both a methylphenidate and an amphetamine-based formulation in treatment. If it is, you need to question it and you need to look for evidence. Here are those different formulations, again, out of your texts, showing, again, the drug, the dose, initial dosing, the parameters, how you would treat patients, max dose, adult, child, that whole group. And again, what I want to bring this vision back to you guys is thinking where we're having some of those issues. Is it execution, perseverance, recall memory? Is it clarity issues, motivation? And so this is where really the differential comes into place to determining really where we want to see the focus of our pharmacotherapy. And do we want something that acts more on dopamine? Do we want something that acts more on norepinephrine? Or do we want something that's kind of hitting both of those? And so it depends, again, on the phenotype presentation of the ADHD. Now, this is just to kind of go into a little bit more of the mechanism of action. And so when we think about our methylphenidate medications, what we're really looking at is, noradrenaline, dopamine, and methylphenidate, right? So the methylphenidate is our drug. Dopamine and noradrenaline are our naturally occurring neurotransmitters. Now, we have our dopamine or our noradrenaline in these different vesicles. You have your presynaptic axon terminal, you have your synaptic cleft, and then you have your next meeting axon. So these vesicles will move to the border of the axon terminal, and they will release the dopamine and the noradrenaline, right? And so what we want is that they don't get reabsorbed, and that's where the methylphenidate comes in. It will move into those receptors, and then we have either more of the dopamine hanging out in the axon terminal, or we have more of it sustained in the synaptic cleft along with the noradrenaline. And this, keeping more of this around rather than it being reabsorbed and pulled back out, allows for that the desired function, right? So decreasing the impulsivity, improving attention and concentration, helping with clarity, all of those different things, right? And so this is really kind of just to give you guys a little bit of a visual of how some of these mechanisms work. Similar to methylphenidate, we have the dexamphetamine mechanism of action. And so same thing, we have dopamine, we have noradrenaline. We come in and we see that the vesicles are releasing those into the synaptic cleft, and we have our dexamphetamine that comes in and blocks these receptors, so that again we have more of our neurotransmitters left to do what they need to do and function the way that we need them to function, to increase the neurotransmitters action on the receptors. So you guys should have had that mechanisms of action and physiology covered, but I do want to make sure that you guys understand that, because as we go, into patient treatment and we look at what our potential neurotransmitter issues are, that's really going to help us determine where we start in treatment. Now we have the non-stimulant pharmacologic recommendations for ADHD. We have pure non-stimulant. It's a norepinephrine reuptake inhibitor, the Strattera, or the atamotexine hydrochloride. We have atypical antidepressants, tricyclic antidepressants, alpha agonists, and different cognitive enhancers. And if the patient is treatment resistant to stimulants, this is where we might see some adjuvant therapies, or if there's complications or comorbidities, we may see additive effects. We know that there's different side effect profiles, and we do have to manage those when we're thinking about the mechanism of action of the drug, as well as the time of onset to the therapeutic effect. And we see what needs to be managed with or as alternatives. And depending on the drug, because of the different formularies, there might be age limits or there might be weight-based dosing that we have to take into account. And so those are also things that have to be considered in selecting the pharmacotherapy. Again, those comorbid disorders may be more pronounced with stimulants, and so anxiety tends to increase when we use stimulants, and so do tic disorders or Tourette's. And so a parent may actually prefer not to start the child on a stimulant, so they may request an altered first-line therapy option, and if that fails, then they might be willing to start a stimulant. But so it's really, again, it's important to educate our patients and their families to make the best decisions but we have to listen to what their priorities are. So it's really important to know, kind of what your full range of options are for your patients and your families. These are your non-stimulants, right? So you have your antidepressants, both imipramines, desipramine, nortriptyline, bupropion. You have your alpha agonists, your different clonidine formulations, and your guanfacine. And so again, these are too small for you to see. There's so many of them. It's just really understanding using algorithm how you might be presented with these. So in your non-stimulant formulations, right? These are my tables. I put the effort into developing those. It would behoove you to be familiar with these green tables, right? Don't worry about the snapshots of the drugs, but these green tables and the resources that I posted for you guys we'll review again on Wednesday. But again, you'll see all of these different drug classes, their duration of activities, and so how you might initially start the dosing and then how you'll kind of move up from there. And again, a lot of the non-stimulant formulations really have a lot more of those weight-based dosing parameters. When we are looking at stimulant medications and adverse effects and their management, I really want to spend time on this slide on Wednesday. So rather than going into this at this point, we will come back to slide 36 and really kind of talk about what that might look like in the case vignettes and in the discussion. But what we see is these are known on the left column. There are known adverse effects from stimulant medications. We know that these exist. These are expected side effects, right? This is not a surprise that these things happen. When they do happen, these are management strategies that we can take and make recommendations to our families and our clinicians, right? You never want to change the therapy without speaking to the provider, but we can educate the families that there are things that we can do to make some of those modifications to help the child be more successful. In the non-pharmacologic treatment, it is absolutely essential that behavioral therapy is a included part of the actual treatment. It incorporates different educational interventions for the child, the family, school, whether you're at work, because again, depending on where your age and where you're at with their ADHD, the different environments present. And so we also realize that structured environments reduce distractions. Having limitations on stimulating activities, taking breaks from those activities. It's very easy to turn, a child over to technology time to distract them because they're needing attention or they're really kind of hyper, but that's kind of giving a negative feedback. And so it's really going to be hard to break those things, and why it's so important that these behavioral therapies are incorporated with the entire family. Contingency training, these are token systems. It really requires a lot of effort on the family's part, but we see this a lot in schools. There's, appropriate rewards. And so those, rewarding positive instead of being punitive to negative, it really kind of takes a positive spin on these maladaptive behaviors. And so children want more attention, and rather than being punished for inappropriate attention seeking, they're rewarded for positives. And so it's really focused on finding the positives in what's happening, and it takes a lot of energy and effort. And unfortunately, it's underutilized. There's a multimodal treatment of the study of children with ADHD, and it's a great study that really kind of talks about each of those different, the importance of each of these different approaches. We also have dietary habits. There's some studies that are showing gluten-free diets help to improve the behavior and function and learning for children with ADHD. And there's something called the Feingold diet. And so if you want to be a little bit ahead of the game on Wednesday, you can certainly look that up. But we also have somatic interventions. And so we see a lot of the neurofeedback or biofeedback as opportunities to kind of help build in that self-regulation. And so we see a lot of this happening because we know that there's a lot of trauma and abuse, neglect, things that will happen quite frequently with children who have mental health issues, and parents who have maladapted or inappropriate responses or a lack of resources and support. And so they just get to their wits' end and they can't manage their own behaviors, and they certainly can't manage the children. And so they end up sometimes with other issues on board. And so these neurofeedback and biofeedback opportunities really start to teach that self-awareness and self-regulation, and they've shown a significant amount of benefit in the literature. So when we think about approaches for pharmacist interventions to support childhood psychiatric care, we really see the role that pharmacists can play in terms of the education of parents and families about symptom progression, watching for certain side effects to present in the child and early catching those so that we can adjust the treatment and we don't push a child into tic disorders, which is very common it's got an increased risk in patients using stimulants. But we also see how things change between childhood, adolescence, and into adulthood. We do know that untreated childhood ADHD leads to significant awareness of social and occupational impairments in adulthood. We've seen reportedly in different studies that people who are struggling with social and occupational impairments in adulthood, if they're screened and they go back, there appears to be a very clear pattern of undiagnosed ADHD, right? Undiagnosed and untreated, or diagnosed but still untreated or undertreated. Bi-monthly evaluations are recommended during the trial period, and then quarterly once they're stabilized and optimized on treatment. So we need to do frequent checks initially to make sure these things are progressing in the right way, and then every 90 days or so to make sure that they're maintaining appropriately. We want to attempt the lowest dose for the maximal effect, and then titrate as needed, and as the adverse effects are tolerated. Once we start to see them manifesting, we need to make some modifications because we don't want an aversion to the medication, which creates a battle between the parent and the child. We have to assess for cardiovascular risk factors, especially when there's family histories. And so we have seen that become a really big focus for children who are starting stimulant therapy. We also look at the pharmacologic treatment and what its efficacy is in childhood ADHD, and how there's equity in adults, and it should be advocated for them to have access to care. We see a lot of stigma, and we can recognize it and appreciate it in children, but for some reason we don't appreciate that in adults. But we do have to recognize that as we put more and more on our plate, and we have fewer and fewer coping mechanisms and strategies, there might appear to be these ADHD diagnoses or behaviors when truly there's other things going on. And so that's really where counseling, behavioral approaches are necessary. We also have to acknowledge that there's a high substance abuse potential for adolescents and adults with ADHD. So being aware of the abuse and misuse is important in counseling and in monitoring. And then again, talking about the disease, normalizing it, removing the stigma, and identifying ways to minimize that. And so we'll kind of spend some time Wednesday talking about vacation holidays, right? Or medication holidays, and the pros and cons of what that might be for children with ADHD. When we look at approaches, for pharmacists that are specializing in peds and neuropsych, we can help with that continuous assessments, right? We can look at drug utilization reviews, looking at adverse effect monitoring, recommendations and exploring genetic testing. We see more and more of that coming into the market. And again, we'll kind of touch a little bit on that. Advocacy in primary care, services in primary care, which is kind of where I'm at, and how to contain costs. But really looking at how do we, how are we judicious in the use of our medications, but also in advocating for behavioral and cognitive support. And so we have a tendency to have an increase in polypharmacy when we have patients that are being treated for ADHD. So it's really important that we communicate clearly to the parents that behavioral modifications should be attempted first, and it's not like, oh, we tried this once and it didn't work, but we implemented this change across the entire family unit and in all of the environments, and this is not enough, but you still have to continue it. If behavioral is not enough, then you do stimulants as first-line pharmacotherapy, and if that's still not enough, then you may add additional medications or switch, to a non-stimulant or other medications, depending on the symptoms and comorbidities the patient is experiencing. Now, when we talk about the pharmacogenetic testing, there is a company, Harmonix, and they are a company that sells genetic tests with Rite Aid and some of the other grocer chains outside of Florida, but there are cheek swab tests that can be performed and sent out for testing, and we'll kind of go over some of those a little bit more Wednesday, but this is just to kind of go through the process in which this company does their testing and how they focus on certain receptors and neurotransmitters and pathways. And so if there's certain receptors, in the P4 system, we'll see some of those things, presenting. And so it just really looks through this. And again, I'll show you guys some additional things from Johns Hopkins and where we're at with the genetic testing. So that's going to conclude the foundation for our lecture, and I will focus on slides for us on Wednesday, as well as some of the resources, and we'll do our case vignettes. So thank you for your time and attention, and I look forward to going through some of these in more detail and answering questions on Wednesday. Have a great day.